I think it's my pleasure and honor to invite Dr. Rajesh Fogla sir for the next talk. And I think all of us are going to learn tremendously from this talk in how do we deal with a cataract with an corneal endothelial disease. So I think that's a very good option, and we have some limited experience in fine ERMs of doing EDOF, and they seem to be working quite well. So I think we should be able to do now more and more in these borderline cases where you feel that maybe a trifocal is out of question. So I think this is likely to be in the future. Yeah.
I think it should have come. Check, ask him to check there.
Yes, please.
Try that side.
So dexamethasone implant is a good choice in treatment naive eyes. So if the patient has been previously treated with an anti-VEGF, I would still go ahead and treat the patient with anti-VEGF and not with the dexamethasone implant. And right now, if we are combining any cases with the cataract surgery, we would go for dexamethasone implant. But otherwise, I would use the anti-VEGF. And we have lots of studies like RISE and RIDE, and lots of studies saying that aflibercept is the king of anti-VEGF right now and approved for diabetic macular edema. So if a patient does not have a cataract surgery, I'm sorry, if the patient does not have a significant cataract, I would still go ahead and do the anti-VEGF injections. But the anti-VEGF injections would be a big load because repeated injections, it's not cost effective. So that is the reason many patients still come and ask to us instead of us giving an option to them. They come and ask for the dexamethasone implant.
No, no, you connect to VGA and see sometimes.
So topical non-steroidal and anti-inflammatory are useful up to some extent, but in some cases of spongy edema where there is no subretinal fluid or where there is no, in a very, very minor or spongy edema cases, I would try giving a non-steroidal anti-inflammatory drug. And in special in cases who they does not want to take any injection, in patients whom the visual acuity is quite good. So I would try using them and delaying as much as possible. So, so I keep them on for an anti-inflammatory agent for about 6 weeks, not more than 6 weeks. And if they do not respond within 6 weeks, they are not likely to respond further.
Good afternoon, everybody. At the outset, I would like to thank Shail for making me part of this instruction course. I'll be talking about cataract surgery in eyes with Fuchs dystrophy, no financial interest to disclose. Fuchs dystrophy is usually bilateral, characterized by gutted formation, thickening of the DM, loss of endothelial cells, has an autosomal dominant inheritance with a slight male preponderance. And if you're not very careful when you're examining your patient on slit lamp and you focus on the cataract, this can sometimes be missed. You have to specifically focus your slit lamp onto the endothelial layer of the cornea and look for these orange peel kind of appearance. You can look at the guttae on retroillumination as well. And specular microscopy shows you the dark areas. And if you have anterior segment OCT, you will see an increased central corneal thickness. And a thickness, the decimus membrane will also look double layered, duplicated, bright, high reflective, and you can see those bright specks on the endothelium. Patients will typically come with early morning blurring of vision, glare at night, which are again coexistent with cataract as well. Sometimes these can be attributed to the cataract. And because of the combined problem with the cornea and the cataract, they can present early. So the decision will be that whether you want to do the cataract or you want to do a combined surgery. With the advent of the Scheimpflug imaging, you can even use the Pentagram to try and ascertain, because sometimes when you have the central corneal edema, the posterior corneal curvature gets affected more before you start seeing changes on the anterior surface. So looking at that posterior elevation where instead of the cornea, the cornea is getting, the posterior layer is getting depressed towards the anterior chamber. That can also help you identify and also stage the procedure. That means you can know that the patient is worsening over a period of time if you do serial pentagram imaging. A normal attrition of the endothelial cells varies between 0.3 to 0.5%. You do get an 8 to 10% endothelial cell loss when you do cataract surgery. And usually in cases with compromised endothelium, you tend to do the soft shell technique. And the study published back in 2005, where they used pachymetry as a cutoff, 640 or more, they found that the eyes which had a thickness of more than 640 more frequently required keratoplasty compared to eyes where the corneal thickness was less than 640. Advantage of doing a cataract surgery alone is that the patient does not need to use medications for a longer period of time. All the complications associated with endothelial keratoplasty is not there. They need to come less frequently to the clinic for checkup. And the disadvantage is that the vision deteriorates as the Fuchs dystrophy progresses. If you have to do a cataract surgery, you can choose the technique depending on the expertise of the surgeon. It's not necessary that you have to do a phacoemulsification all the time. Sometimes if I have a patient with compromised endothelium and a very hard cataract, I would resort to doing a SICS on an extracapsular surgery rather than trying to do a phacoemulsification. If I have eyes with very shallow anterior chamber, hard cataract, compromised endothelium, doing a decompression procedure like doing a limited pars plana anterior vitrectomy helps you open up the space and gives you more working space to perform the surgery. And taking into consideration that patient would require an endothelial keratoplasty, you choose a hydrophobic IOL because hydrophilic IOL can get opacified with air or gas tamponade. The lens power selection also, knowing that the hyperopic shift that can occur with endothelial keratoplasty, you will choose an IOL that is +1, which gives you -1, -1.5 postoperative refraction, which will offset the hyperopic shift that you see with endothelial keratoplasty. During surgery, make sure that you use sharper knives. So for me, if I'm doing a patient with compromised endothelium, I know that the decimus attachment is not as tight as normalized. I will make my paracentesis first, fill the chamber with viscoelastic, make the eye nice and firm, and then I'll make my other paracentesis and the main incision. Because if the eye is soft and you're trying to make your incision, you cause a little bit of DM detachment at both the side port and the main incision, which can progress either during the surgery or in the post-operative period. Use BSS for irrigation. In these eyes, avoid intracameral medications because we are so used to using for dilatation, for antibiotics. So these are things when you have an endothelium that's not working well. Using intraocular solutions, you have to be very careful what you're placing inside the eye. Instead of hydrating the wounds at the end of surgery, I would rather, if I have a leaky wound, I will place a suture. Hydration would work when normalized here where the decimus is loosely attached. If you hydrate, there is a possibility that any detachment, you can make it progressively worse. You can always leave a small mid-size air bubble post-operatively because this air bubble will help, if there are any small DM detachment, it will help reposition them and provide them tamponade. Need to use steroids for a greater frequency because if you have compromised endothelium, you need to keep the inflammation to the minimal. You can use topical 5% sodium chloride in the post-operative to tide over the a little bit of corneal edema that can occur after the surgery. If you're using steroids more frequently, monitor the IOP because raised IOP can also result in the corneal edema getting worse. And do an anterior segment OCT if there is edema to identify DM detachment, which can be seen very well on anterior segment OCT. If you do get corneal edema, don't panic. At least 8 to 12 weeks it can take to resolve because I get call from surgeons who operate and within a week they want me to do a DMEC for the. So I tell them, at least wait for 8 to 12 weeks, unless you're pretty sure that you have removed the DM during surgery. Then there is no point in waiting 8 to 12 weeks. Do an anterior segment OCT and look at the serial pachymetry. That means you have a patient, explain to the patient what the position is, do a ASOCT map, look at the pachymetry values or do a Scheimpflug imaging. And then every week when the patient comes or you're reviewing it, do the pachymetry again. If you see your pachymetry is getting better, then you know that the eye is improving. If the pachymetry is not getting better or if it is getting worse, then it is likely that this cornea may not improve over a period of time. There is increased risk of endothelial failure if there is presence of posterior folds or epithelial edema, you see a lot of the guttae which extends all the way to the periphery. Sometimes you get Fuchs, the guttae are only limited to the center, but the peripheral cornea looks fine. Those are eyes where the edema will resolve. But if you have guttae going all the way to the periphery, then maybe doing a combined surgery would be much better. So cutoff would be that if your package is less than 650, but cell counts more than 1,000, maybe you can just do a cataract surgery alone. If your package is more than 650, but cell counts are between 800 to 1,000, these eyes are at a greater risk of developing corneal edema. So you need to discuss with your patient and figure out whether they would be comfortable doing a sequential surgery or whether you would go ahead and do both at the same time. But if the cell counts are really low, then you can plan for a combined procedure. Now, sometimes I find that if you see a post-keratoplasty eye where PKP has been done, the cell counts are usually in the range of 600, 700. And then in those eyes, we go and do a cataract surgery, the cornea remains perfectly fine. But those are, if low cell density, but those are normal cells. And they have less intracellular junction, so the amount of fluid that can leak into the cornea is much less. Here you have abnormal cells with a lot of dead cells in between, which allow more fluid to leak into the cornea. So the cells are not able to pump back the fluid. So that's where the difference is between a low cell count in a post-keratoplasty eye doing well, but here, even with cell counts of 800 to 1,000, the cornea can fail. What you can do if your Fuchs dystrophy changes are limited only to the central 4 millimeter area, you can just do a stripping of the decimus in that area and allow the peripheral endothelial cells to migrate, something which we rarely see in our clinical practice. The other procedure we can do is DMEC. A DSO is something which is done under viscoelastic. You use a microforceps, initiate a break in the decimus, and you just do like a capsular excess, you do a decimeter excess, but only in the central 4 to 5 millimeter area. That's practically in the visual axis. But remember, you have to tell your patient that immediately after this procedure, there's going to be edema. They're going to a drop in the vision, which can take anywhere between 2 to 3 months to improve. Use of Rho kinase, topical Rho kinase inhibitors can help speed up the resolution of edema, but the patient should be prepared that it will take time for the edema to resolve. Advantage is that they may not need to use steroids for a long time because there's no risk of rejection. Disadvantage is that in 3 months, if it doesn't recover, then you'll have to undergo a DMEC procedure. So this is one of the papers published back in 2019 where they showed good results with DSO combined with use of topical ripasuril. But when you have extensive changes like that, you can do any of the endothelial replacement procedures, whether you are DSEC, ultra-thin DSEC, or DMEC. These have replaced the traditional penetrating keratoplasty. They give more predictable refractive outcome, faster visual recovery, and lesser risk of rejection. Studies have shown that combining cataract surgery with a DMEC procedure does not alter the success rate or the outcome of DMEC surgery. This is one of the patients where we have done a triple procedure in one eye, then we went ahead and did in the other eye, and you can see that both the eyes look great and they have good endothelial cell count and good visual outcome. This is again another patient after the cataract surgery, non-resolution of edema, where we went ahead, did a DMEC, had a good outcome. Phakic eyes, young patients with Fuchs who can present with this, you can do a DMEC first, let that resolve, and then the patient can come back, and whenever the cataract develops, you can do a cataract surgery. So that's another option, because sometimes in Fuchs, who present early where the cataract is not present, you can do a DMEC first, and later on, the refractive outcome of those surgeries are better, because then you can plan whether you want to put a toric IOL, EDOF IOL, or a multifocal. Whereas an existing pseudophakic, sometimes you may not venture out because you don't know what the final K value will be or what would be the final astigmatism. So a lot of surgeons are now moving on to doing a sequential procedure where they do the DMEC first and then follow up with the cataract surgery later. The edema, the hyperopic shift is because of in DMEC, because of the central edema resolving faster than the peripheral edema. Because of the faster resolution of central edema, it makes the posterior curvature more steep. So that's why you get a hyperopic shift. But when the peripheral edema resolves, this hyperopic shift goes away. This study published back in 2013, they looked at the outcomes of cataract surgery following DMEC. All eyes achieved 20/30 or better. They had, and were within the plus or minus 0.5. The cell loss was pretty similar to what you see with standard cataract surgery. So these are basically the options in Fuchs dystrophy. You can do a cataract surgery alone, followed by endothelial keratoplasty. This is a nice flowchart that I have for all what I have spoken, which summarizes depending on Fuchs dystrophy, whether you have an asymptomatic or a symptomatic patient with clear lens or with a cataract, and you can plan the surgery depending on the cell count and the pachymetry. So newer diagnostic methods quantify corneal changes in Fuchs dystrophy, helps us monitor progression. Choice of procedure depends on patient's expectation, how long the patient is willing to wait. And advanced techniques have definitely improved the refractive outcome. In future, the cell therapy where you culture the endothelial cells and inject into the anterior chamber, that's a definite possibility, and it will change the way we manage Fuchs dystrophy in future. Thank you for your patient hearing.
Thank you, sir, for that masterclass on managing cataract and Fuchs dystrophy. Just one doubt or one question, sir. If you if you have planned possible sequential, that cataract, and let's see how things goes, if it
Correct.
decompensates, then in those cases, do you post-operatively give Rho kinase inhibitors or any other suggestion?
See, the Rho kinase inhibitor will only work. The Rho kinase inhibitor helps speed up the migration of the cells from the periphery to the center. But if your center part in Fuchs, the dead cells are still there, by adding Rho kinase, it will make that epithelial edema worse. It will give rise to what is called as a honeycomb epithelial dystrophy, where you will get thickened epithelial. Patient's visual acuity will actually drop. But if you have significant amount of healthy cells in the periphery, then a Rho kinase can work by allowing these cells to migrate to the center. But a lot of times when we see patients for DMEC, they actually come back earlier for DMEC because their vision drop is more with the use of Rho kinase.